to the staff who are here this morning, hearing some great presentations, and to our veterans and family members in the audience, welcome. And we're happy you're here. My name is Shana Rodriguez. I'm a public affairs specialist here at James A. Haley. And it's my pleasure to moderate this afternoon's conference. So just a couple of housekeeping. Clinicians who did not yet sign in at the registration tables for the afternoon session, please do so you can get credit. Sonia in the back there will be happy to help you. After each presentation, there will be some time for some questions from the presenters themselves, but I do want you to know that there will be a 30-minute question and answer session from a panel right here where we'll have the floor is yours to ask any questions that you would like, so please do keep that in mind. That's taking place at 3:30. And during this time, please do limit your questions to those that are appropriate for an open forum, as this is a public event. And we do have some hospital representatives here who will be happy to assist you with any clinical, personal concerns that you have. So thank you again to our speakers who have traveled from all corners of the country to be here today. We really do appreciate you sharing all of your valuable information and insight with us. And this is all for the benefit of our veterans, so thank you. Now, it is my pleasure to introduce Mr. Joe Battle, Director of James A. Haley Veterans Hospital and Clinics.
Well, good afternoon, everyone. If you were here this morning, welcome back. If you were here just for this afternoon, welcome. We are very privileged to host this conference today for Gulf War illness, and I think it's very important that we do these things where we keep up with what's going on both clinically and what our veterans are seeing with the illness as it manifests for them. So what we've done today is we've had speakers, and we're going to have more speakers and panels this afternoon to discuss Gulf War illness, the issues going on with it, and how we can move forward and continue to try to improve in dealing with this issue. And so I want to thank you for being here today. It's very important that we work together in dealing with this, because this has been a very a difficult illness to deal with since the 90s, because the absolute causal factors for all of it is still nebulous, and so developing treatments has been difficult, but we're still working toward those ends and trying to get there. So that's why we're doing conferences like this, to try to help us get better and help you get better. So thank you very much for being here today. I hope you have a great afternoon, and thank you for coming. And please know we feel privileged to work here and take care of veterans, and thank you for your service to your country. So thank y'all very much.
Thank you, Mr. Battle. Our first presenter today is Rakib Rayhan, an MD, PhD candidate at Georgetown University Medical Center and Howard University in Washington, D.C. Since 2010, he has worked with Dr. James Baraniak on functional neuroimaging as a chronic pain and fatigue research center. His fields of study are cognitive psychology, biological psychology, and neuropsychology. Welcome, Mr. Rayhan.
Hi, everyone. My name is Rakib Rayhan. Thank you for having me here. So today what I'm going to talk about actually is the research that I've been doing since 2011. Long story short, we put people in an fMRI or in an MRI, and we see what their brains do before and after exercise. So in general, we all know that about 30% of the veterans who served in the 1991 Gulf War have Gulf War illness, and the symptoms of fatigue and headache, sleep disturbance, GI complaints, so on and so on. Obviously, many of these are phenological, and so this is pulled from Dr. Lee's paper, Dr. Steele's paper, and what we've seen is that there's obviously significant findings where Scud missiles and pesticide treatments have possibly led to the symptoms that we see today. Next slide. So, one of the big questions that I've been trying to study for the past, close to 6 years, is can neuroimaging really provide insights into the symptoms that our veterans have? And the answer looks like yes. What we've seen is that in using neuroimaging in other types of illnesses like chronic pain and fibromyalgia, what we've seen is that when you use some of the neuroimaging modalities, they see unique differences. And so neuroimaging and the modalities that we do use does have tremendous promise. So one of the hallmark symptoms that a lot of our veterans do complain about is something called exertional exhaustion. And what that is after some sort of heavy exercise or heavy lifting or some sort of activity that is very strenuous, many of them complain that they have a crash. And that crash lasts for 2 to 3 days. So my mentor and the PI of my lab, Dr. James Farnick, he created a protocol where he wanted to kind of put this together and see what's really going on in the brain. The object, or the way the study is set up, is we take a brain scan before, just a baseline brain scan, and then we take the veterans and we exercise them on 2 consecutive days, and then we take a brain scan afterwards, and we see the differences within the brain when it comes to their function. Next slide. So this is pretty much the protocol, and oftentimes we call it the sandwich protocol. As you can see, there's 2 brains on each side and 2 exercise bikes in the middle. And the overall protocol is around 4 days. So veterans will come in on the first day, they'll get the screening day. They'll get that first baseline scan, which is a resting state scan. And it's about an hour scan, and some of our veterans here have partaken in the study. Can anyone raise their hands if they've been a part of the study? Yes. Okay. And after that first baseline scan, we put them on a bike, and it's a VO2 max full aerobic exercise protocol, and we do it consecutively. Then we see what happens to their brain afterwards. The whole purpose of this is, can we recapitulate the idea of exertional exhaustion? Something that many veterans do complain about still today. Do veterans here have exertional exhaustion? Anyone? Yes? Yes? Okay. Throughout the protocol, not only do we take brain scans, but we also take serial blood samples, we take fatigue, pain ratings, a multitude of other ratings as well. And one of the things is, when they're in the scanner, what we try to look for is not only just baseline activity, but we also put them through something called a working memory task. So another thing about exertional exhaustion that our veterans do complain about is when they do something that's very strenuous, and they try to do something that's maybe cognitively demanding, they feel like they have brain fog. They feel like they can't get out of neutral, I think is a good way of putting it. And so what we do is we do a working memory task before the exercise, and we do that same type of working memory task after the exercises to kind of see what's going on cognitively, whether or not there isn't a big difference within the brain before and after exercise. So when you look at the protocol, you can kind of look at it in 2 ways. One, we can look at it in a cross-sectional, which means we can the veterans come in, resting, and we can kind of see what their brain looks like then. And at that, where the red box is at least, you can look at the structure of the brain. So you can look at differences when it comes to the gray matter and when it comes to the white matter. And in the purple box, it's a more of a longitudinal type of study where now you can compare the differences in functional activity before and after exercise. So the next slides will show the cross-sectional changes, and then we're going to go into the causal changes or the longitudinal changes before and after exercise. Okay, so the first study that we published in 2013 one of the things that we saw in our clinic, and one of the things I did notice was even the veterans that I was able to sit on with Dr. Bernick, was that their pain and their fatigue complaints fluctuate in parallel. Now, what that means is that a veteran would come in and say, you know, my fatigue rating is a 10, and my pain rating is a 10. I had veterans who would come in and they say, oh, my fatigue rating is an 8, my pain rating is an 8. And so what we saw was that consistently those two would be intimately linked. Never were the scores ever really far apart. And so at that point, from prior studies, what we saw was that there were differences in the brain's white matter, which is pretty much the large wires within our brain. They connect these hubs that we call gray matter. And they're kind of, like wires. And so we hypothesized that most likely there's probably differences within the white matter that may explain the pain and fatigue that our veterans are going through. Next. So this is really technical, but long story short, the method that you use to kind of look at the white matter is called diffusion tensor imaging. And in summary, what it does is it just looks at the integrity of the white matter. And it gives you these numbers that tell you about how thick or how thin or how less or how more the white matter is within the brain. Okay, this is also a big detailed method. You can see that too. So the demographics of the initial study was that we had around 31 Gulf War illness veterans, or CMI veterans, and we had 20 controls. And next slide, so those are the demographics. And initially, just the subjective thing that I saw was the increase in pain that fluctuated with their fatigue that was often parallel. What we saw was, when we put on a graph and you look at it from an objective point of view, you do see that consistent fluctuation. Next. Oh, actually, can you go back? So this slide right here where we show fatigue and we show pain, one of the important things is that this is actually nothing novel in the sense of that a lot of prior studies, a lot of prior professors or PIs have shown this, right? We all know that many of our veterans do complain of pain and do complain of fatigue, and that it's chronic. But one of the things that we didn't know at that time was what underlies this consistent chronic pain, this consistent chronic fatigue. We still didn't know. And so the novel or the new thing that we were looking at was the white matter changes. So what we saw was that in multiple regions or multiple white matter tracts, we saw that the damage in the tract correlated with the severity of their pain and their fatigue. Next slide. So this one is pretty much the main or the most important part of that study. And what we saw was that if you look at the scale on the left that says ordinal fatigue on a 0 to 4, and you look at the dolorimetry, which is a measure of pain or hypersensitivity or hyperalgesia, and then the McGill total score is a questionnaire. So one of the things is that, and if you look to your left over here, AD stands for axial diffusivity, and it's a measurement, one of the measures of integrity in the white matter. So what we've seen is that as the values of fatigue and pain either increase, or in this case here, as they become more sensitive with dolorimetry, the values of AD increase. So increased AD correlates with increased fatigue and increased pain sensitivity. That's what the data here shows. And and one of the things that we were also looking at was whether or not this type of damage can be used as a predictive biomarker. Can we use it to really see whether or not veterans in the future that we would study may have this type of damage as well? So we did something called a receiver-operator curve to kind of assess the sensitivity, specificity, whether or not you can really separate them. It's not that great, but the key is that it's very promising, let's just say, because it's the first time that anyone has really looked at diffusion tensor imaging in MRI and tried to assess it for biomarker potential. Next one. So, after we found this really exciting thing, well, what does this tract connect? And one of the things is that this tract is actually called the right IFOF. And the IFOF stands for the inferior frontal occipital fasciculus. It's a long word. So, but one of the important things is that if we consider your white matter to be, let's say, a wire that connects, let's say, telephones or like hubs within your brain, one of the key and most interesting things is the right IFOF connects gray matter regions that are really implicated when it comes to pain processing. So the ventromedial prefrontal cortex, it's pretty much right above your nose, the bridge of your nose right here. And then your insula is another pain region, which is kind of in the middle of the brain, right behind your ear, right on there. And then you have your lateral cortices. But long story short, consistently, all these regions have been shown in the literature to process pain. And what we've seen is that the more damage that we see in our veterans, the higher their pain ratings are, or the higher their fatigue ratings are. So that was a really exciting finding for us. It was the first time anyone has ever correlated something like that. And it was also the first time that someone used diffusion tensor imaging or structural imaging to see whether or not biomarkers could be translated in the future. So, if we remember the initial slides where we had the two brains and the sandwich and the exercise bikes and everything like that. So, this second study, or the second part of these slides, really goes into the crux of the study that we did and the protocol that Dr. Baranek developed. And that is whether or not exercise affects brain function. And in this study, what we looked at was something called BOLD, which stands for, there's a lot of acronyms in neuroimaging. It stands for blood oxygen level dependent flow, which long story short means that when you do a cognitive task within an fMRI, it causes increased blood to those regions, and we pick it up as a signal. Another type of MRI imaging we used was voxel-based morphometry. It quantifies the gray matter, or the amount of gray matter you have within a region. And then another thing that we took was from not only prior discussions with veterans, but also looking at chronic fatigue syndrome, is that many patients will complain of autonomic dysfunction, right? Tachycardia or some sort of dysfunction in that matter, cardiovascular indices. And so throughout this protocol, this 4-day protocol, we took supine or lying down and standing blood pressure measurements. And we subtracted those two to look at the change. And we also measured pain, so yeah. Oh, and I just went over this, yeah. Next slide. So one of the really exciting things was that if you look at the black arrow, that's the time of that first exercise. And prior to that exercise, if you look at the circles and the triangles and squares, so the controls are circles, and the triangles and squares are actually our Gulf War veterans. So after the first exercise, what we noticed was a subset. A third of our veterans actually had orthostatic tachycardia. And what that means is that when they were lying down and when they stood up, they actually had an increase of their heart rate above 30 beats per minute, something that we did not see before exercise. So we called them the START group, because what we realized was that it was a stress test associated tachycardia. We induced the tachycardia. We wouldn't have seen this change if we did not stress their system. And so it happened to a third of the veterans, and then the other set of veterans that did not have an increase in tachycardia, they actually had an increase in pain indices. So they had increase in hyperalgesia, and we call them the STOP group. So we have the START group, and we have the STOP group. And the STOP group stands for Stress Test Originating Phantom Perception. Now we'll go into the fMRI in a second, but what's important here is that what we see now is that the exercise which tries to recapitulate the idea of exertional exhaustion, objectively now shows that, yes, this type of excess work or something that's physically demanding does lead to some sort of quantifiable change within their symptoms. So that's great, right? That sounds awesome. But one of the things is, does this correlate to anything within their brains? So at that point, once we established those two groups, we looked at their brain functions and we separated them out. And what we saw was that compared to controls, our stop group, or let's say our pain group, right, and our start group, which is our tachycardia group, they had unique differences in their brain function. Now, if you look at the photo here of the start group, this is the picture of the cerebellum, which is like this little cauliflower-looking thing in the back of your head. And what we see there is that start group has excessive amount of activity in comparison to the stop and the controls. So what we hypothesized was that they were recruiting that as compensation, kind of to, complete the working memory task that they were doing. Oh, by the way, so we were taking this bold fMRI while they're doing a working memory task. And and then now in the stop group, what we saw was that during the working memory task, even though we weren't assessing their pain in any way, shape, or form, we saw regions of the brain like the basal ganglia that were activating, which are implicated in pain processing. So even though if they were focusing on a task or focusing on doing the working memory task, we still saw regions that were implicated in pain. So it was almost, the pain was constantly in the background, something that was always there, almost like a distractor. And controls, well, compared to the literature, they were controls. They showed very normal activity in all regions. So then this is the after exercise. Now this was really striking. Our start group, or our tachycardia group, showed no significant differences in their activity anymore. It's almost like the brain just stopped. Whereas our stop group, they consistently showed activity again in those pain regions. And our controls showed again, consistent activity in normal working memory regions, as we would say. So one of the key things that we brought out from this pre and post exercise difference was that not only did we have two unique clinical phenotypes, but we also had two unique fMRI neuroimaging phenotypes as far as what their brains look like before and after exercise. Excellent. Okay, so now to that voxel-based morphometry part. So one of the things that we did was we looked at the volume of the gray or white matter. Versus that first study where we looked at the integrity of the white matter, we kind of now looked at the amount of gray or white matter, so the mass that's in their brain. And what we saw was that patients that we consider start, the ones with the high tachycardia, they had atrophy in regions that are, from a clinical perspective, often known to control heart rate. So if you look at picture B, picture D, and clearly you see these regions here. And those regions that are red are showing that they had brainstem atrophy. Something, again, that was never reported, and something that we were really shocked to see, that people who had increase in heart rate or tachycardia had actually atrophy in regions that in medical school I learned controls heart rate. So it was a really great finding in the sense of putting all those things together. A shows atrophy in the lateral occipital region, which is the pain regions, which is A shows the stop group. Yeah, and C does. Next slide. So that was the prior studies from 2013, 2014. Now currently, what we're trying to do really is not only recruit more veterans, but really get to the point of biomarker development. And how do we do that, right? Number one, we're recruiting, or we have already recruited. But number two, the main thing is we're going to use machine learning. What machine learning is, we're going to look at patterns within the brain, assess those patterns as part of a large group, and then see whether or not that pattern can be used to classify new subjects that we see. Next. So here's kind of like the step one of this machine learning thing. So, same veterans, right? And this is just an example, but before exercise, as you can see, if you compare to controls and veterans, you don't see too much of a difference. But after exercise, we see that veterans have a tremendous difference in these unique regions compared to controls. Next slide. So, step 2 is, once we've identified these unique regions, what we do is we take these regions and we tell pretty much the computer to create an algorithm, a pattern, and we try to assess that pattern with a new colon. So, next slide. So once you establish that pattern that you see that you think maybe the GWI brain signature, what you then do is you take a new set of veterans, brand new, something that the pattern or the algorithm or the computer has never seen, and you run them through, and it's almost like a sorter or a sieve. And the computer will try to separate out whether or not one person is a veteran or a control. And that tells you whether or not that pattern that you initially saw was indeed robust to separate out Gulf War veterans. So that's where we're at right now. Hopefully in the next couple months I should be done the analysis on that to see whether or not that really holds. But this is kind of a summary of everything that I have learned for the past, goodness knows, 6 years. We've seen, the exposures, and there's so many of them, and they're so variable. On top of that, you have not only the exposures, but also the genotype and the environmental variables. And then what we've seen is from our unique subgroups, individual pathophysiology, that kind of leads to the endpoint of the similar symptoms that we see across veterans, but they're all still variable. And it's been very difficult to tease apart, but I do still feel that our work has been promising. The fact is we're moving forward to get to the part of biomarker potential. And then this is just the last slide, kind of showing where we're trying to go, which is the machine learning route. And hopefully we can find actual predictive markers from the neuroimaging data that we have, and really find something robust where when we build a model and we put a new brain or a new functional imaging brain of a veteran within this model, that the model can identify whether or not this person has Gulf War illness. The hope is it becomes a clinical biomarker, something that's non-invasive, something that is also short in time. I mean, many of these scans take 7 minutes, so something that won't be too expensive. And I think that's an ideal biomarker in the sense of short, inexpensive, quick, no needles. So I think there's a lot of promise in neuroimaging. And that should be the end of my talk. Any questions?
What is the age group of your subjects?
I'm sorry?
Age group.
Age group? On average, they were between 40 and 50 in the 2013 study. They're still right now around, 40, 45, 50, something like that. But it ranges, right around there. It ranges. Yes?
I participated in Dr. B's CFS study. Now, they couldn't do an fMRI on me because I have a fusion of two discs.
Mm-hmm.
Is there another kind of scan that they can do to see what is going on in the brain? Because, you look at, in my case, I know that, to me, it is apparent there's a brain damage going on there.
Sure.
And what I'm trying to do right now is, I've had CT scans, PET scans, and all that done in the past, and I've recently had a new series done.
Right.
And I'm hoping that a neurologist will be willing to sit down, look at the two image sets, and say, okay, compare the old ones to the new ones, say, oh, that's why your brain's all, not working correctly.
So currently, right now, MRI technology hasn't gotten to the point where professors or clinicians are, I guess, comfortable at this point to put someone in there with metal for long periods of time, just because not only are they concerned about the well-being, but if the metal starts heating up, there's just so many other things that can go wrong. But currently, I do not know of any new tech out there that would allow someone with fusion plates to go into an MRI.
Okay.
Yeah, sorry about that. Any other questions?
So after the exercise, you noticed that the different groups had that particular area in their brain atrophy? Or is that-
Oh, so the atrophy is actually static, right? So one of the ways that we, I think, look at the data is that when I was going through the clinical files and actually putting it into the Excel sheet and just being completely blunt honest, I started noticing that a couple of our veterans had this tachycardia. And, going back to the literature is something that we kind of, I'd kind of seen, but it wasn't really ever reported upon. And so at that point, I went to Dr. B and I said, I think this could be a unique subgroup. Let's continue to look into the data and see what we get. And sure enough, we got a third of our veterans that showed this exercise-induced tachycardia without looking at anything else. So at that point, we thought, you know what, if this is a unique group, let's go back to their MRI data and then separate them and then see what we find. And so that the exercise itself didn't cause the atrophy. The atrophy was already there. It just happens to be that because we saw this clinical change, we went back to the data and separated that based upon that clinical change, and then we were able to see the differences, right? Because if we just looked at controls versus all the GWI, like just put together, we wouldn't have seen those differences. So it's almost like a go backwards analysis. Yeah.
On your increased heart rate group, do you ever look at other parameters like multiple concussions, blast exposures? Are you asking that question?
Dr. B, are you asking those questions? Yeah.
Yes.
He's the head honcho. I gotta get back to him.
With the providers, I think some of the providers are still in the audience.
Yeah.
What would you recommend for them to include in their clinical skills related to what you found?
Boy, so a stress test. I think one of the things that can be incorporated is the clinical stress test. I think the MRI and the functional imaging, those might be difficult to incorporate into a current clinical setting. But what we saw when it came to the exercise-induced tachycardia, the reason that we were able to find that was one, a bicycle, and two, a blood pressure cuff that is an NEBA. So if somebody would like to, as far as incorporating it, an exercise test and a blood pressure cuff is something that is easily put together. Yeah.
You did have changes, being one that went through this, you had changes with blood pressure and pulse, sitting, standing, and lying. And typically when we come into the VA,
Right.
you get the little finger thing and you
Yeah.
get one reading sitting down. You have to ask them
Right.
to do a sitting and standing
Right.
5 minutes after.
So the key is actually the sitting and standing. We did that before the exercise, right? So we lied them down and then we stood them up. And we saw no difference. It wasn't until we actually stressed their system, we put them through that exertional exhaustion that many of our veterans have complained about to us, where have told us that this feels like a crash. I can't get out of bed. I can't do any. I can't even I can't brush my teeth. I've heard the stories and it's debilitating. And so it wasn't until we stressed them did we see that type of tachycardia. So if
Possibly a physical therapy consult to put them on a bike and have it done.
right, I think that might be the most realistic way of trying to maybe recapitulate what we saw here. Yes.
So physical therapist, the exercise doc in the physical therapy department, you could have a consult and have them.
I would think that's feasible.
And
Yes.
that's never done in the VA. I don't think any of us vets that are here have had it, right? So we're looking for ideas for practitioners. of what
Right.
they can do.
Rebecca,
Yeah.
this is just a pilot study that hasn't been verified, right?
So, good question. We actually just finished the verification study about 3 months ago, and I'm going to be analyzing the data once I get back to DC. So hopefully it will verify everything that I showed today.
It's very interesting because my cardiologist cannot figure out what the world's going on. And it's not even being heart monitor, but all the tachycardia, and they don't know in the world what's happening.
Yeah, I mean,
And it's pretty incredible. It's after I'm even driving a car for 6 hours, my heart will start doing whatever it does. So it's very interesting.
it was very novel, very, someone else, yes.
I was going to say also, if I remember correctly, that it affected our oxygen levels on the sex time we got on the bicycle, the second one. It went low.
Oh, wait, I don't recall, Dr. Reed?
It depends on the subject. Some people have a decrease in their amount of oxygen and others don't. So I have to look at the whole set all over again. And in response to your question, as far as the stop and start difference, we were able to confirm that.
I'm sorry, there's too much noise over here.
We need to use the microphone, Dr. Veronica, so we can all hear.
Come on down. Yeah, come on down.
You know I was in the artillery and I can't hear you.
So, as far as the difference between lying and standing, we were able to confirm that change after exercise in Gulf War homeless people. So that's a good indication that we're headed in the right direction as far as confirming these other findings. The MRI stuff takes a long time to process. And
How many people did you have?
it's about 30 in the first one, and it's close to 40 in the second one.
All right, that's the end of it. Thank you, everyone.
So our next speaker is Dr. David Goldsmith. He's an occupational and environmental epidemiologist with Georgetown University in Washington, D.C. He's an expert on environmental and workplace health with a particular interest in fracking, silica, silicosis, and cancer risks, respiratory illness and exposure to paints and welding fumes, and the chronic health effects, including cancer, associated with pesticide exposure. He teaches a summer class on veterans' health and employment issues at George Washington University. Welcome, Dr. Goldsmith.
Thank you very much. I'm quite honored to be here. Delighted to have an opportunity to share with you some insights that I've gained from collaborating with Dr. Berniak, and I'm trying to understand the tremendous strides that have taken place and the implications for his work. In my case, I would like to use the concept of the Gulf War syndrome and the Gulf War issues as a means of thinking about a broader spectrum of veterans, namely those who are coming back from Iraq and Afghanistan today, because we have gained a lot, and I think we need to keep in mind some of the lessons that we have learned as we move forward. So I'm hoping this might work. Okay, next one, please. Just a smidgen worth of bona fides for this audience. I was a member of the Gulf War Syndrome working group that met for the second volume that was done by the Institute of Medicine, published in 2003. This was a group, this Gulf War panel looked at solvents and pesticides. And I have to be honest with everyone in this room to say that as a scientist, I was skeptical that there was a there with regards to Gulf War syndrome. And what I mean by that is that there didn't seem to be something definable, something clinical, something that would allow us to test relationship between exposures and some health outcome. And that is the reason why I labeled myself a skeptic. And I want to say, quite honestly, I no longer feel that way. And it's basically because of your work, Jim. There's no doubt that you have shown me and many other people that there's a lot more to this than we thought, and we should sort of not go forward with blinders on with regards to where we are looking at other kinds of issues related to veterans' exposures. I do think that we need to think very critically about Gulf War veterans and apply that thinking to current veterans, and that's really what I'm going to spend a little bit of time this afternoon talking about. And the reason I wanted to do this is to share with you two new published papers that look at more current types of exposures. And I hadn't thought of this when I put this material together, but you folks in Florida are thinking about the Deepwater Horizon much more so than we are outside of the Gulf states. So nevertheless, I hope that you'll bear with me as we take a look at some of this evidence. I also want to take a look at the question and the link between cardiac and respiratory ailments related to IED explosions in the current set of returning veterans. And lastly, I want to say something very briefly more in the terms of an editorial, if I could make it that, about military sexual assaults. Next, please. Okay. Very briefly, this is from the Gulf War, the top 10 environmental exposures based on a paper given in 2005 by my colleague, Dr. Schneiderman. The first is protective gear and alarms. The second is diesel kerosene and other petrochemicals. The third are oil well fire smoke. Fourth was ate local food. Fifth was insect bites. The sixth was harsh weather, smoke from burning trash and feces within 1 mile of a missile warfare, repellents and pesticides, paint solvents and petrochemicals. And as you can see there, on this top 10 list, there isn't something specific about camisea. There isn't something specific about that issue. These are based on data that are now over 10 years old, but I just want to point you out of this was a sample of 651 returning veterans. This was an issue, a set of issues at that time. Next one, please. By way of contrast, this is from Afghanistan and Iraq. Returning veterans, much more recently, just again the top 10, or not top 10, top 6. Smoke from burning waste, sand and dust storms, gasoline, jet fuel, diesel fuel, depleted uranium, paint solvents and other petrochemicals, and oil well fire smoke. So those are the top 6, even though it says top 10, apologize there, for returning veterans from Afghanistan and Iraq. Notice that there is some overlap between the two. There's concerns about oil well fire smoke and sand and dust storms and things like that. And I just want to point these out because, you know, we have to try on the epidemiology side of this equation to be aware of what the concerns are that veterans are expressing to us. And here I'm speaking for the epidemiology community, but also by inference, that's the clinical community too. Next one, please. Very briefly, and this is not so important in this audience, but the three groups that we need to be paying attention to. The first one is right in the middle, Gulf War, 2.3 million veterans, and now there are 2.2 million who are in the veteran system. There's peacetime at 5.8 million, which we're really not focused on so much. And then from 2001, for the last almost 15 years or so, we've got 1.6 million veterans, of which 2.5 million actually served, and these numbers are somewhat out of date, I apologize. But it's important to keep in mind that there are a lot of veterans from different groups, and what we need to do is to think about information that they give us that we will then use to evaluate the health of veterans going forward. Next one, please. I do think that these things have been covered pretty well, and for time reasons, let's just keep on going. This is the Enduring Freedom, Iraqi Freedom. The list of military or environmental health issues is longer than the Gulf War, and they include things like blast injuries, which we'll talk about, but they do include some things that overlap. Animal bites, dermatologic issues, mental health issues are much more of a serious concern for returning veterans, and many of you in this room know about PTSD, you know about traumatic brain injuries. These are things that are really pushing people in military medicine, pushing people in veterans issues to pay attention to problems that are being seen at the VA and so on. Traumatic brain injury, vision loss, respiratory health, reproductive health. These are some new things and some overlapping things. Next one, please. The first I want to share with you, the first author is Jani, J-A-N-I. This was just published in the Annals of Internal Medicine. They use data from the Airborne Hazards and Open Burn Registry voluntary online survey to look at deployment history, respiratory symptoms, non-military exposures, burn pit exposures, and blast exposures. And they use data from over 42,000 enrollees. And one of the interesting things that they observed was that veterans were telling them who had respiratory ailments about issues related to burn pits, but they also mentioned that many of them seemed to be in close proximity to IED explosions. That is close enough to feel an actual explosion per se. It was higher among those with cardiopulmonary symptoms than those who were volunteers in this survey who didn't have that exposure. So they did an epidemiologic, I'm not going to go into the details here, but they did make some adjustments for differences of age, sex, branch of service, body mass index, smoking, burn pit exposure, and non-military exposures to dust, gas, and chemicals. And next one, please. I have a couple of illustrations of what we're talking about here. This is an IED explosion that's in a group of rangers who are out on patrol. Next one, please. This is one in Iraq where there's a severe hole that's been put into the ground because of the explosion. The vehicle has been knocked over on its side. These are things up to the current time that clearly are related to traumatic brain injury, without any doubt, clearly related to the loss of limb, clearly related to severe head trauma, and so on. But for the most part, and this is an important point, had been thought of as risk factors for respiratory issues, and that's what I want to share with you. Next one, please. The authors found a new association linking self-reported cardiopulmonary symptoms, that is shortness of breath and decreased ability to exercise, with exposures to IED or other blasts. This produced an adjusted odds ratio of 1.66, and I've given you the 95% confidence intervals, so it's what we call statistically significant, controlling for all of those previous covariates. In other words, if you wanted to make some sense out of this, we controlled for the things that might also explain for a side association, and they are controlled for in this evaluation. This is what we call a hypothesis-generating exercise, so it needs confirming studies, but it is very interesting that we are finding this relationship now, and this is something that we need to look at going forward. Next one, please. This is some data on the Gulf War Horizon Coast Guard response. It is information and data from a colleague of mine at the Uniformed Services University of the Health Sciences in Bethesda, Dr. Rushecki. She looked at Coast Guard responders who were on duty from April 20th to December 17th, 2010. They assessed these Coast Guard members for active and reserve duty and compared their military health information with members of the Coast Guard who were on duty at the same time but were not serving in the Gulf. That's an important point. You may have seen that in some prior designs earlier today where there were people who were deployed to the Gulf War, and they were compared to people in the military who weren't deployed to the Gulf War. This is an appropriate way of designing a good epidemiology study. Their concerns here were exposures to crude oil, oil dispersants, heat, and other issues from this time period, April 20th to December 17th. And as I say, it has direct relevance to Coast Guard responders as well as civilian health people, because there were people on the civilian side of this equation. Yes, please, next one. Just a couple of illustrations. Here's a couple of Coast Guard crewmen doing some capture of some crude oil. Next one, please. This is where you got some cleanup. The Coast Guard is actually wearing these Tyvek suits, but you can see that the suits themselves have some of the crude oil on it, and that's the concern that we have in Dr. Rushecki's analysis. Next one. So I don't want to try and bore you, but I'll try and give you some highlights here. This is an evaluation of any respiratory effect, and every single one of them, including coughing, shortness of breath, and wheezing, are all related, comparing no exposure with low, medium versus high exposure. And you can see that this thing called P for trend, that goes less than 0.01 in every instance. This means that the trend is statistically significant. And what it says is that these kinds of respiratory symptoms are greater amongst those with the highest exposure. Next one, please. This is a larger picture looking at some other symptoms, neurological symptoms, including headaches, lightheadedness, and those are the statistically significant ones. There are others which do not show statistical significance. In other words, they don't show a higher effect for the higher exposure. And at least in this analysis, they are not thought to be related to exposure to the Deepwater Horizon oil cleanup. Next slide, please. This is dermal exposure, skin rash or itching, that was shown to be linked and was statistically significant, and it got a proportional odds ratio of 1.87. Next one, please. These are data for gastrointestinal symptoms. Any gastrointestinal symptom is shown to be linked. That also includes diarrhea, stomach pain, but then when they looked at constipation, nausea and vomiting was not as strong as any gastrointestinal effect or any stomach pain or diarrhea, but it was statistically significant, again adjusted for the same kinds of things that we're talking about. Next one, please. These are genitourinary symptoms, burning or painful urination, did show statistical significance there for exposure to Gulf oil kinds of exposures. However, when they looked at things like cardiovascular effects, they found no association. In other words, the risk does not go up in the same way that as the previous ones did. And in fact, although the last one does show some modest dose response, sudden heartbeat changes, it's still not statistically significant. So we've got some murky areas to be aware of. And this is not uncommon when you do epidemiology research as we're talking about here. Next one. These are the incidents, these are new cases of health conditions among active duty Coast Guard members. And the ones I want to draw your attention to is only on the bottom. Dermal conditions are in bold, and they appear to be higher in the responder group, the people who actually responded to the Gulf oil spill. There is headaches and migraines shows a relative risk of 1.8, but all of the others are sort of mixed up and murky and don't really point in any particular direction. So you've got some mixed information where using the medical record, which is what we've got here, shows some effects on the dermal conditions, but the symptoms show a different effect, where the symptoms seem to be more related than the new data that are in this follow-up survey. Next one, please. These are acute respiratory symptoms. Chronic respiratory symptoms and asthma are related. These, again, are data from the medical record of all of the people who served in the Coast Guard, comparing those who were actual responders to non-responders. And then dermal conditions, again, show an increased risk. I just do want to draw your attention, even though they're not statistically significant, there's a higher risk for chronic obstructive pulmonary disease, a higher risk for headaches and migraines, and a higher risk for neurological conditions. But given the fact that this is a breakthrough study, this is something that needs to be studied again, at least in my opinion. Next slide, please. This is a reminder to me, and it's a reminder to everyone in this audience, that the projections from the year 2010 up to 2040 is that there's going to be a large increase in the number of female veterans. And the reason I want to make this point really clear is that, leads me to my next slide, is that we need to apply the thinking that has led us to deconstruct and better understand what's going on with Gulf War veterans. We need to apply some of that same skill to understanding and preventing military sexual assaults. And I know that for those in this audience who are concerned about environmental issues, this isn't quite so much on point, but as I said, it's my afternoon editorial speaking out. We have at this point in time, given what's going on with Hollywood and the news media, a much higher focus on assaults in the American workplace. And we, in public health, and we on the clinical side, have a duty to prevent and treat victims of military sexual assault. And unfortunately, some of that is going to fall on the shoulders of some of the people in this room, because you're seeing these patients at the VA. This means denying enlistment to anyone with sexual assault history, so that we could keep those people from ever joining our military forces. This also means that commanders must set a very high bar with regards to sexual assaults and bring charges when necessary without waiting for something more draconian to take place. And as I say, the VA must become a leader in innovative research, focusing on treating and preventing treating military assault victims. Next one, please. Okay, so I really want to say that from my perspective, we do not want to repeat what the Gulf War denial scenario has led us to. We repeated this is the second time. We had the same issue when it came to Agent Orange after Vietnam, and we need not do this over and over again. The VA and military medicine are known for excellent patient care and really incredible technical innovation, without any doubt. We need, and VA and military medicine needs to develop innovative thinkers in epidemiology, which in my opinion has been lacking. In other words, the focus on the VA and military medicine has been on the care side. In addition to developing really strong clinicians in that area, we need to develop critical thinkers and leaders on the epidemiology side of this as well. The work that I shared with you for Drs. Janney and Rushecki, they're pushing aside some of my old opinions. In other words, there's clearly some intelligent and critical people who are in position to conduct this research, and we need to encourage more of them to become leaders and get involved. But having said that, I also think that medical directors need to be bold and unafraid of finding new links between military service and health problems, and in that context, we must become leaders in treatment and prevention of military sexual assaults. Next one, please, which I think is the last. So let me again thank our hosts here in Tampa for their generosity and for their warmth, and ask if there's any questions that I might be able to answer.